In hospital medicine, the growth of PICCs has been astonishing. We have these devices easily available at our fingertips with often just the stroke of a computer keyboard. We thought many years ago that because this has become easier for many providers, that there would be variation in use of PICC lines. So we conducted a survey of hospitalists across the country, and we asked them a series of questions about PICCs. What do you use them for? How do you take care of them? When do you think they're associated with harm? And in what situations do you think they may be appropriate or inappropriate? And what we found was marked variation. Some providers felt PICCs were like IVs. They could go in at the drop of a hat and come out at the drop of a hat without causing complications. Others felt more restraint when it came to using a PICC, actually understanding that they were like a central line, that they were associated with real risks and real complications. So working with the Michigan Blue Cross Blue Shield network, we set up a collaborative quality project looking at collecting data about PICC use across Michigan hospitals. We did this in real time, so we actually are collecting data specifically about PICCs and looked at how patients were getting them, for what reasons, and how long they were staying in. And the data were surprising. So in over 7,000 patients who have received PICCs, about 20% come out within 5 days of putting them in. Almost like an IV, just as we had thought initially. Even more surprising was the fact that it was hard to tell sometimes why the doctor had made a decision to put a PICC line in, largely because we couldn't see that in the documentation in patients' records. Often, the feeling that we were getting was when a patient's IVs ran out or the nurse couldn't get an IV in, you should put a PICC line in them. The challenge with this decision making is that PICCs are not associated with just benefit, but also risks. And so working with our partners then, we decided to create a guideline or a document to help physicians make decisions about what device should be used when, why, and what particular data points a physician should consider when making the decision about a device. This document then brings in experts across various specialties because inherently access in the veins is not a physician-owned domain. In fact, it's owned by radiology, by surgery, by nursing, by oncology, by a number of different physicians, each of which have different perspectives. And we want it to be all-encompassing. And what we did then was crystallize recommendations based upon what type of device a patient would get, how long the device would stay in place, and what would go through the device. Using those three parameters, we were able to create algorithms or workflows through which providers can actually look at what their patient needs, how long they need it, what type of infusion, and what device is most appropriate. So we're really excited about this because now, going back to our Michigan project, we have the ability to inject this across hospitals to see what it does, to actually understand if providers gravitate towards it. And if they don't, just as importantly, understand why not. The way it's designed is really to focus on classical clinical scenarios where you need to make a decision. So the guidelines are set up, for instance, for ICU patients. Within the ICU patient family are different requirements for venous access. Do you need to give vasopressors? Do you need to monitor hemodynamic pressure? Is there an irritant or a vesicant that will be infused? There's also the sense of how long do you think you're going to need access? In many cases, we found physicians have a sense that this is going to be a long-term stay, but don't think about it initially when the patient's admitted. If nothing, I hope this creates thoughtfulness about the decision to place a PICC. The path of least resistance may not be the best path. And this document serves to create a little bit of a structure around that decision making, whether it's placing a PICC for frequent blood draws or placing a PICC for long-term antibiotics. This document gives you that clinical granularity with recommendations from various specialties to be able to make a better decision. And a key focus in usability was to create concise and simple recommendations. So the way we did that was to create very simple color-coded figures where we have recommendations from the panel in green when everyone agreed as being appropriate, yellow as being neutral or uncertain because the evidence didn't help us one way or the other, or red when it was clearly obvious that a device was not the right choice for a patient. These figures or templates then are like pocket cards and can be carried around very quickly and looked at for a particular patient with respect to what device should I be using and when. My ultimate hope is that the lines that are put into patients, PICCs or not, are the right line for that patient. I think a lot of patients get lines that they don't need. Some of them get the wrong line when they need a different kind. And unfortunately, a lot of them have complications from these lines. My goal is to make sure that at the end of the day, we do what's best for the patient, that the provider has all the information they need to make a good decision for their patient, and the use of these devices is both appropriate and safe with respect to outcomes.